Everyone thinks they'll just go to the hospital when WW3 starts. Wrong. Hospitals become primary targets in modern warfare. Infrastructure, power grids, supply chains fail within 72 hours. That emergency room you're counting on? It's rubble or overwhelmed with 1,000 people and 3 doctors. Triage means most people get nothing. Your neighbor with the broken leg? Lowest priority. Your kid with the infected wound? Wait in line. You with your first aid kit? You're holding gauze while people die. Here's what nobody wants to admit. When the hospitals burn, when the pharmacies are looted, your body becomes the only hospital for 100 miles. The ambulance isn't coming. The surgeon isn't operating. What happens when you're holding pressure on an arterial bleed with 90 seconds before someone dies? Your medical knowledge isn't just useful. It's the difference between survival and statistics. Let's build a medical system that survives without hospitals. Before we talk about tourniquets and antibiotics, we need to talk about philosophy. Because if you don't understand the why, you'll waste money on tactical first aid kits that fail when it matters. Your medical system must be 3 things, not 2, not 4. 3. Miss 1 and you're building a very expensive liability. Commandment 1, triage inversion. The anti-dependency protocol. This isn't about stabilizing someone for the ambulance ride. There is no ambulance. You're not providing emergency care. You're providing definitive care with 0 backup. When you stop that bleed, when you clean that wound, when you set that bone, you're the beginning, middle, and end of medical intervention. The patient doesn't get transferred to a higher level of care. You are the highest level of care. In civilian medicine, the goal is stabilization. Keep them alive for 20 minutes until paramedics arrive. Not anymore. Your job is the entire span. Stabilization, treatment, recovery, rehabilitation. All of it on you. Commandment 2, pharmaceutical autonomy. The stockpile imperative. Pop quiz. How many medications can you name that treat bacterial infection? How many do you currently have? How long would your supply last if pharmacies closed tomorrow? For most people, the answer is 0, 0, and 0 days. That's not autonomy. That's complete dependence on a supply chain that stops the moment things get serious. True pharmaceutical autonomy means you've stockpiled the critical medications. Antibiotics, pain management, insulin if needed, anti-inflammatories. You've stored them properly. Cool, dark, dry. You understand shelf lives. Antibiotics degrade. Insulin requires refrigeration between 2 and 8 degrees Celsius. But stockpiling isn't enough. You need rotation. First in, first out. You need alternatives. When amoxicillin runs out, what's your second line? Your third? You need plant-based knowledge. Honey has antimicrobial properties. Willow bark contains salicylic acid. Garlic has legitimate antibiotic effects. The goal isn't a bunker full of pills. The goal is never needing the pharmaceutical industry again. Commandment 3, knowledge as infrastructure. Skills over supplies. Here's the brutal truth. A trained medic with a knife and clean water saves more lives than a civilian with a fully stocked trauma kit. Knowledge doesn't run out. Knowledge doesn't expire. Knowledge doesn't break or get looted or require refrigeration. You can memorize hemorrhage control. You can learn to recognize early infection. You can understand fracture stabilization, wound debridement, fluid resuscitation. This knowledge lives in your head. It's infrastructure you carry everywhere. Equipment fails, supplies deplete. But the understanding of how the human body breaks and how to fix it, that's permanent. These 3 commandments aren't suggestions. They're the difference between people who survive medical crises and people who become casualties. You're not building first aid response. You're building a complete healthcare system that operates independently of civilization. Now let's stress test this philosophy. Let's run it through the first scenario every medic fears. The trauma that won't stop bleeding. Someone takes shrapnel, arterial bleed, femoral, or brachial. You have 3 to 5 minutes before they lose consciousness. Another 2 minutes after that before irreversible brain damage. This is how most combat deaths occur. Bleeding out before reaching care. You are the care. Here's how you engineer survival. The tourniquet protocol, your first line of defense. You need a real tourniquet, not a belt, not a bandana, a cat tourniquet or a soft tee. These are designed with a windlass mechanism that generates enough pressure to completely occlude arterial blood flow. You place it high and tight, above the wound, as close to the torso or shoulder as possible. You crank the windlass until the bleeding stops completely. Not slows, stops. You document the time. Write it on the tourniquet in permanent marker. This matters. A tourniquet can stay on safely for about 2 hours before tissue begins dying from lack of oxygen. After 6 hours, you're looking at amputation even if you save the life. But here's the thing nobody tells you. Tourniquets only work on limbs. What happens when the bleed is in the groin, the armpit, the neck? Areas where you can't apply a tourniquet? Enter hemostatic agents. Hemostatic agents. Chemical clotting on demand. Quick clot, Celox, Gitasan-based clotting powder. These aren't magic. They're chemistry. They promote rapid coagulation by concentrating clotting factors at the wound site. You pack them directly into deep wounds. Junctional hemorrhage, the areas where limbs meet torso. This is where hemostatic agents save lives. Tourniquets can't touch. You expose the wound. You pack it with hemostatic gauze, pushing it deep into the cavity where the bleeding originates. Then you hold direct pressure, not light pressure, crushing pressure, for 10 to 15 minutes without releasing. Your hands will cramp. Your arms will shake. You hold anyway. The IV saline myth. What actually works for blood loss? Most people think you need IV fluids immediately. Wrong. Most people can't start IVs under stress. Shaking hands, poor light, patient thrashing. Your success rate drops to 20%. Here's what works. Oral rehydration salts for conscious patients. The recipe is simple. 1 liter of clean water, 6 teaspoons of sugar, half a teaspoon of salt. This restores electrolytes and fluid volume. It's not blood, but it buys time. Will this save everyone? No. Arterial bleeds with massive tissue damage still kill. Exsanguination from multiple sites overwhelms even perfect technique, but it moves your survival rate from 20% to 70%. That's the margin that matters. You've stopped the bleeding. The patient is stable. Then, 48 hours later, the wound site turns red, hot, swollen. Welcome to the invisible killer. Infection. The threat is now microscopic. Bacteria. No hospital, no lab cultures, no broad-spectrum IV antibiotics. Infection kills slowly, then suddenly. Sepsis doesn't negotiate. Let's talk about practical infection control when sterile is impossible. Early recognition. Your only warning system. You're looking for signs. Expanding redness around the wound site. Heat. The skin feels hot to touch compared to surrounding tissue. Purulent discharge. Thick yellow or green fluid. Fever above 101 degrees Fahrenheit. Red streaking extending from the wound. That's lymphangitis. Bacteria traveling through your lymphatic system toward your bloodstream. The timeline matters. Infection typically manifests 24 to 72 hours post-injury. You're checking wounds twice daily minimum, every 12 hours. You document changes. Redness spreading. How fast? Discharge increasing. What color? Wound cleaning protocol. Mechanical removal saves lives. You can't achieve sterile in the field. Forget it. But you can achieve clean. Clean is good enough. You irrigate the wound with clean water and mild soap or diluted iodine. 10% povidone iodine, diluted 1 to 10 with water. You're not trying to disinfect. You're trying to physically flush out bacteria. Here's the science. Mechanical scrubbing and irrigation removes 90% of bacterial load. The bacteria aren't killed, they're washed away. You do this twice daily, morning and evening. You use gauze or clean cloth. You scrub gently but thoroughly. The patient won't enjoy this. Do it anyway. Antibiotic selection. Educated guessing under pressure. You don't have cultures. You don't have sensitivity testing. You're choosing antibiotics based on wound type and location. For general soft tissue wounds, amoxicillin clavulinate, Augmentin, covers most common bacteria. For cellulitis, skin infections spreading through tissue planes, doxycycline works. For deep tissue or bone involvement, ciprofloxacin. Dosing must be aggressive, not half courses that breed antibiotic resistance. You dose properly. Amoxicillin clavulinate, 875 milligrams twice daily for 7 to 10 days minimum. You don't stop when the patient feels better. You complete the course. The honey and silver bridge. When antibiotics run out, medical-grade honey, specifically Manuka honey, has legitimate antimicrobial properties. It's not a replacement for antibiotics. It's a bridge when you have nothing else. You apply it topically to wounds. Colloidal silver, same principle. Topical use only. These buy time. They reduce bacterial counts. They don't cure sepsis. Sepsis watch. The countdown to death. If infection progresses to sepsis, you're looking at organ failure. Vital signs tell you. Rapid heart rate, above 100 beats per minute. Rapid breathing, above 20 breaths per minute. Confusion. Dropping blood pressure. Cold, clammy skin. If you suspect sepsis, the patient needs IV antibiotics, or they die within 24 to 48 hours. Can you culture bacteria in the field? No. Are you guessing on antibiotics? Yes. But educated guessing based on wound type and symptom patterns beats doing nothing. You've controlled infection in soft tissue. But what about the breaks, the fractures, the bones that snap? A bone breaks. Femur, tibia, radius. Doesn't matter. What matters is this. Can you immobilize it before muscle spasms turn a clean break into a compound nightmare? Here's the truth. Most fractures don't kill you. The complications do. Let's talk about field orthopedics. Splinting principles. Immobilization is everything. You immobilize the joint above and below the fracture. Broken forearm. You splint wrist and elbow. Broken lower leg. You splint ankle and knee. This prevents bone ends from moving, grinding, causing further damage. You need rigid material. Wood, metal, rolled newspaper reinforced with duct tape. You pad the splint where it contacts skin. Cloth, clothing, anything to prevent pressure sores. You secure it firmly, but not so tight you cut off circulation. Check distal pulse every 2 hours. That means the pulse point farthest from the heart. For arm fractures, check the radial pulse at the wrist. For leg fractures, check the dorsalis pedis pulse on top of the foot. If you lose the pulse, the splint is too tight. Loosen it immediately, or you're causing ischemic damage. Traction splints. For femur fractures specifically, the femur is surrounded by massive thigh muscles. When it breaks, those muscles spasm and contract violently. The broken bone ends are pulled past each other, overlapping. This shortens the leg. Worse, the jagged bone ends can lacerate the femoral artery. Arterial bleed inside the thigh. The patient exsanguinates internally. A traction splint prevents this. You create mechanical tension that pulls the leg straight, counteracting muscle spasm. Improvised version uses rope, a stick for ankle attachment, and leverage. You're not healing the fracture. You're preventing the bone from shredding the artery. Pain reduction is secondary to arterial protection. Reduction techniques. Realigning displaced fractures. Some fractures displace. The bone ends shift out of alignment. You need to realign them. This is called reduction. You apply traction, pulling along the axis of the limb. Someone else applies counter-traction, stabilizing the body. You pull until the bone ends slide back into anatomical position. Do this within 2 hours of injury if possible. After that, swelling makes it nearly impossible. The pain is extreme. Sedation would be ideal. You probably don't have it. You do it anyway, because unreduced fractures heal wrong, causing permanent disability. The amputation calculus. When do you cut? This is the question nobody wants to ask. When is the limb unsalvageable? When does keeping it kill the patient? There's a scoring system. Mangled extremity severity score, MES. If blood flow can't be restored within 6 hours, tissue dies. If you have massive contamination plus bone pulverization, infection risk approaches 100%. If the limb is attached by skin alone, nerves and vessels destroyed, it's already dead. Amputation in those cases is life-saving, not failure. Field amputation without anesthesia. Tourniquet first. Cut through soft tissue with a scalpel or sharp knife. Saw through bone. Ligate major blood vessels with sutures or clamps. Leave the wound open for drainage. Don't close it. Infection risk is too high. Survival rate, if done correctly, 60 to 70%. Survival rate, if you do nothing and let sepsis develop, 0. Will you perform amputations? Probably not. Should you know how? Absolutely. Because the decision point is binary. Cut or watch them die in 72 hours. You've handled acute trauma. But what about the slow killers? The chronic diseases that grind on for months? The world didn't end in an explosion. It just stopped refilling prescriptions. 6 months into WW3, the pharmacies are empty. The factories are rubble. And your neighbor needs insulin. This is the grind. Let's talk about keeping people alive when the pills run out. The insulin crisis. The diabetic death sentence. Type 1 diabetics die without insulin. The timeline is weeks to months depending on severity. They spiral into diabetic ketoacidosis. Their blood turns acidic. They become confused, then unconscious, then dead. Stockpiling is critical. Insulin requires refrigeration, 2 to 8 degrees Celsius. Shelf life is 18 to 24 months when stored properly. Outside that range, it degrades. Potency drops. You're injecting volume without effect. Rationing strategies become necessary. You reduce dose by 20 to 30%. You tighten carbohydrate control aggressively. No sugar, minimal starches. You accept slightly elevated blood sugar, 150 to 200 milligrams per deciliter instead of the ideal 80 to 120. Not healthy long-term, but it extends your insulin supply. You're buying time. Can you manufacture insulin in the field? No. Can you extract it from animal pancreases like they did in 1921? Theoretically, yes. Practically, no. The purification process requires laboratory equipment you don't have. Your diabetic dies when the vials run out. Hypertension management. When blood pressure medication disappears. ACE inhibitors, beta blockers, diuretics. They run out. What's your alternative? Extreme sodium restriction. Under 1,500 milligrams per day. No salt added to food. No processed foods, which are all gone anyway. No canned goods if you can avoid them. Potassium supplementation helps. Bananas, potatoes, Leafy greens if you can grow or find them. Potassium counteracts sodium's effect on blood pressure. Herbal diuretics have mild effect. Dandelion. Hawthorn berry? They're not pharmaceutical grade. They might drop blood pressure 5 to 10 points. Better than nothing. Not good enough for severe hypertension. Here's the reality. Some people will stroke out. You can't prevent it. You don't have the medications. You accept this. Or you drive yourself insane trying to save everyone. Asthma without inhalers. Suffocation in slow motion. Bronchodilators and corticosteroid inhalers are finite. When they're gone, severe asthma attacks become potentially fatal. You can't breathe for someone. Alternatives exist, but they're weak. Caffeine is a mild bronchodilator. Strong coffee during an attack might help. Might. Ephedrine from ephedra plant. Mahuang is more effective but carries cardiac risks. Elevated heart rate. Arrhythmias. You're trading breathing problems for heart problems. Prevention becomes everything. Eliminate triggers. Avoid smoke and dust. Maintain the cleanest air possible. Keep the person away from allergens, mold, animal dander. You're managing their environment because you can't manage their lungs. Medication preservation. Extending what you have. Cool, dark, dry storage. Extends shelf life 2 to 5 years past expiration for most medications. Heat and moisture are the enemies. You vacuum seal everything. Mylar bags with oxygen absorbers. You store in the coolest location available. Basement, underground cache, anywhere temperature stays stable. You rotate stock. First in, first out. You use the oldest medications first while they're still potent. You save the newest for later. The triage protocol. Who gets the last vial? This is the choice you'll face. You have 1 vial of insulin left. 2 people need it. 1 is 60 years old, 1 is 12. Who gets it? 1 is a doctor with critical skills. 1 is someone's parent. Who gets it? There's no right answer. Only the choice you can live with. You make it. You move on. You don't have the luxury of ethical debates when resources are finite and people are dying. Can you manufacture insulin in the field? No. Can you extend what you have and keep someone alive 6 more months? Yes. And 6 months might be long enough for infrastructure to return. Might. But medications aren't the only thing that runs out. So does sanity. PTSD doesn't wait for peacetime. Depression doesn't care that you're surviving. Your group has 3 suicides in 2 months. Someone's having flashbacks so severe they're dangerous. Let's talk about mental health when psychiatry stops existing. Psychiatric medication reality. The withdrawal nightmare. SSRIs, antipsychotics, mood stabilizers, finite supply, dangerous to stop abruptly. Withdrawal triggers psychosis, seizures, suicidal ideation. You need tapering protocols. Reduce dose by 10 to 25% every 2 to 4 weeks. Gradual step down prevents acute crisis. Stockpile critical medications. Lithium for bipolar disorder. Antipsychotics for schizophrenia. Without them, some people become non-functional or dangerous. Trauma and PTSD management. Field psychology basics. You can't cure PTSD. You can prevent complete collapse. Grounding techniques help. 5, 4, 3, 2, 1. Name 5 things you see, 4 you touch, 3 you hear, 2 you smell, 1 you taste. This pulls people out of flashbacks, reconnects them to present reality. Peer support circles. Structured sharing. People talk, others listen. Connection matters. Isolation kills. Sleep hygiene despite chaos. Dark sleeping area. Consistent schedule. Sleep deprivation amplifies every mental health problem. Suicide prevention. Direct intervention. Warning signs. Withdrawal. Giving away possessions. Sudden calm after depression. Talking about death. You ask the question directly, are you thinking about killing yourself? Not euphemisms. The specific question. You remove means, weapons, medications, ropes. You institute 24-hour watch rotation. Someone stays with them constantly until crisis passes. The exhaustion epidemic. Psychological collapse from chronic stress. Chronic stress plus sleep deprivation plus moral injury equals breakdown. You prevent this through enforced rest rotations. Task variation prevents monotony. Small rituals maintain humanity. Morning coffee. Evening stories. Something normal. Community mental health structure. Designated listeners trained in active listening. They witness pain without trying to fix it. Weekly group processing. Structured time to acknowledge grief and fear. You don't force healing. You prevent suppression that leads to explosive breakdown. Can you cure PTSD in the field? No. Can you prevent suicide and keep people functional? Sometimes. And sometimes is better than watching your group disintegrate from the inside. Each skill in isolation is incomplete. But when they integrate, when trauma care, infection control, chronic management, and mental health become a system, you create something greater than the sum of parts. So what is the ultimate wartime medical system? It's not a kit. It's not a bunker full of supplies. It's a person or a small team who understands that medicine is a system, not a specialty. Let's talk about integration, layered defense model, how skills compound. Trauma skills stop acute death. Infection control prevents delayed death. Chronic management extends life. Mental health prevents internal collapse. Each layer supports the others. You don't just treat wounds. You prevent the infection that follows. You manage the PTSD that develops. It's interconnected. The medical team concept. Redundancy prevents failure. Minimum 3-person medical cell. Primary medic handles trauma and procedures. Pharmaceutical manager controls inventory and rationing. Mental health coordinator manages community support. Cross-training is mandatory. If one person dies, critical knowledge doesn't die with them. Supply chain as system. Tiered prioritization. Tier 1, life-sustaining. Insulin, antibiotics, epinephrine. Guard these with your life. Tier 2, quality of life. Pain medications, antihistamines. Tier 3, nice to have. Vitamins, supplements. Rotation and preservation protocols for each tier. Knowledge distribution. Preventing information extinction. Written protocols in waterproof binders. Step-by-step procedures. Suturing. Wound packing. Fracture reduction. Illustrated guides. Teaching sessions bi-weekly to spread skills across the group. The training pyramid. Distributed competence. Everyone learns basic trauma care. 25% learn intermediate skills. IV starts, advanced wound care. 10% learn complex procedures. Surgical drainage, chest decompression. Pyramid structure prevents knowledge extinction if specialists die. Feedback loops, continuous improvement. After-action reviews for every medical event. What worked? What failed? What to change? Failures are learning opportunities. You adapt, you improve, you survive longer. This doesn't make you a hospital. It makes you a functional medical system, operating at 1800s technology level. But 1800s medicine kept people alive. It's crude, it's limited, and it works. You've built the system. You've trained the team. You've integrated the skills. Now here's what that means when the missiles fly. What does this look like in practice? Let me walk you through the build. Knowledge foundation. Books before bandages. 3 books minimum. Where There Is No Doctor, by Hesperian Health. Military Field Manuals. FM 425. 11. The Survival Medicine Handbook. Read them before crisis, not during. Knowledge first, equipment second. Pharmaceutical stockpile. Tiered survival. Tier 1. Amoxicillin clavulanate, 6-month supply. Ciprofloxacin. Doxycycline. Insulin if needed. Epinephrine autoinjectors, EpiPens. These are non-negotiable. Tier 2. Pain management. Tramadol, ibuprofen. Antidiarrheals. Antihistamines. Storage. Cool, dark, vacuum sealed. Equipment list. Tactical medicine essentials. Tourniquets. CAT, soft T. Minimum 4. Hemostatic gauze, quick clot. Chest seals. Nasopharyngeal airways. Suture kits, scalpels. Forceps. Irrigation syringes. Vibration dampened storage to prevent damage. Surgical capability, field operations. Sterile field kit. Surgical drapes. Betadine. Gloves. Masks. Basic surgical tools. Scalpel handles with blades. Hemostats. Scissors. Needle drivers. Local anesthetics. Lidocaine if available. Training regimen. Stress inoculation. Monthly hands-on practice. IV starts on training arms. Suturing on pig feet or silicone pads. Tourniquet drills under time pressure. Practice while exhausted, cold, in darkness. Stress inoculation makes skills automatic when adrenaline hits. You're not building a first aid station. You're becoming the last line between life and death for everyone you care about. You're the physician, the pharmacist, the surgeon, the psychiatrist. You're the hospital. When the sirens wail, when the bombs fall, when the hospitals burn, you'll be the only medicine for 100 miles. And the people you love will be counting on you. You can hope the hospitals survive, or you can become the backup plan. Just don't wait until the pharmacies are empty to start learning. The clock's already ticking.